So, hello everyone. Today it's really a great pleasure and honor to have Dr. Jacky Chan with us. He is a private cardiologist and also a cardiac electrophysiologist in ProCare Heart Clinic at Hong Kong. He was formerly associated with Honorary Clinical Assistant Professor of Lia Ka-shing Faculty of Medicine at University of Hong Kong, and also as a consultant cardiologist of University of Hong Kong Shenzhen Hospital. And really, it's a great pleasure for me to introduce him because we did spend some of the really great times when we both were doing the 2018 HRS scholarship in St. Luke's Medical Center as well. And Dr. Chan initially graduated from Faculty of Medicine at University of Hong Kong, later on in also EP training further at Westmead Hospital at University of Sydney, Australia. He has been innumerously trained in a lot of other subspecialties as well, including various short-term overseas training complex, ICDs, EP courses in US, South Korea, in mainland China as well. In fact, he has also received Society of Cardiovascular CT Level 2 competency training in cardiac CT, and is the customer of Society of Echocardiographic Examination of Special Competence in Adult Echo. So, and he's also IBHRE qualified as well. And as I said, he's a person who is multi-talented, and really today is an honor to share our time with him to learn about a very important specialty about cardiovascular disease in the COVID-19 patients. So over to Dr. Chan now.
Okay, thank you very much, Professor Nareen Kumar, for your kind introduction. And I'm really honored to be invited to deliver this talk to the Global Heart Rhythm Forum community during this viral pandemic. COVID-19 and cardiovascular diseases. So I have nothing to declare, but I must confess that I am not an expert in COVID-19. This is the outline of my talk. I'll talk about COVID-19 epidemiology, mechanism of cardiovascular complications in COVID-19, cardiovascular complications of COVID-19, the role of ACI and ARB in COVID-19, and finally, the treatment of COVID-19 and the drug interactions with other CV medications. So this is the Johns Hopkins Coronavirus Resource Center dashboard, and the data was retrieved from the dashboard just yesterday. So up to the 2nd of May, more than 3 million people have been infected by COVID-19 globally, and it has caused more than 200,000 deaths. And the case fatality ratio varied quite significantly from countries to countries, ranging from 4 to 5% in Germany and China to over 15% in Italy, France, United Kingdom, and Belgium. And this is the situation in Hong Kong. Up to yesterday, we had about 1,000 cases of COVID-19 infections, and we had 4 mortalities. So the case fatality ratio is about 0.04% in our city. When you look at the age-adjusted mortality rate in mainland China, for those people under the age of 60, the overall mortality rate is about 1.4%. But when you get older, you could see that for those people older than the age of 80, the case fatality ratio is more than 13%. So the mortality rate increased dramatically above the age of 60s. And many older people also have coexisting cardiovascular diseases, which could be a risk factor for COVID-19 infection. And this could also be associated with increased risk of cardiovascular complications of COVID-19. When you look at the Italian data, they have a similar mortality profile when you look at the age-adjusted fatality rate. For those under the age of 60, the mortality rate is about 1%. But for those older than the age of 60, you could see the mortality rate increased from 3% to 20%, especially for those older than 80 years old. the mortality rate ranged from 15 to 20% in China and Italy, respectively. People with cardiovascular diseases are more prone to develop COVID-19 infection. When you look at all confirmed, suspected, and asymptomatic cases, the overall prevalence of cardiovascular disease was about 4%. Looking at a meta-analysis in mainland China, including over 1,500 people, the overall cardiovascular disease prevalence was about 8%. When you focus on the inpatients, especially in the Wuhan cohort, prevalence of cardiovascular disease was between 8 to 15%. But the prevalence of CVD is much higher in ICU COVID patients, and it was about 25%. This is the CDC data just released in March. And when you look at the overall prevalence of cardiovascular disease in this cohort, it was about 28%. And for people older than the age of 65, about half of these people had pre-existing cardiovascular diseases. Cardiovascular disease increases the risk of COVID-19 associated mortality. For those people with no coexisting mortality before COVID-19 infection, the mortality rate was far below 1%. However, for people with pre-existing cardiovascular diseases, the mortality rate was about 10%, and is 10 times higher versus those without pre-existing comorbidities. So why is COVID-19 more prevalent in patients with cardiovascular disease? First of all, we have to go back to the mechanisms of the Renin-Angiotensin system and the cardioprotective roles of ACE2. When you look at this schematic diagram, starting from the left-hand side, you could see angiotensinogen is converted by renin into angiotensin 1, and then being converted by ACE1 to angiotensin 2. And angiotensin 2 binds to the AT1 and AT2 receptors, and the AT1 receptors would trigger a series of reactions resulting in vasoconstriction, fibrosis, inflammation, and cellular proliferation. So the role of renin inhibitor and ACI inhibitor and ARB is to block this inflammatory cascade, resulting in a protective cardiovascular protective mechanism. However, at the same time, renin-angiotensin inhibition might potentially enhance ACE2 expression as well. And ACE2 will convert angiotensin 1 to angiotensin 1,9 and 1,7. And angiotensin 1,9 and 1,7 could result in vasodilatory effect, anti-inflammatory, and anti-proliferative effect. So in short, ACE2 has cardioprotective role through angiotensinogen 1,9 and 1,7 through vasodilatory and anti-inflammatory mechanism. So this schematic diagram tells us how the SARS-CoV-2, the COVID-19 coronavirus, binds to our cells. This is the ACE2 receptor on our cell surface. So the coronavirus spike protein binds to the ACE2 receptor and is being endocytosed. Once being endocytosed into our cells, it starts viral replication. And the viral replication produces a lot of COVID-2 viruses, and these viruses will then be exocytosed after a series of viral replication. However, ACE2 are not only present in the lungs, they are also highly expressed in the heart, blood vessels, kidneys, and gastrointestinal tracts. SARS-CoV-2 virus binds to the ACE2 receptor and results in disruption and downregulation of ACE2 receptors on the cellular surface. This results in upregulation of inflammatory cytokines, which causes pulmonary and myocardial inflammation, resulting in acute lung and cardiac injury. This is the second mechanism through which SARS-CoV-2 virus suppress our immunity. CD209 is a protein expressed on macrophage surfaces, and SARS-CoV-2 virus also binds to CD209. Binding of this coronavirus to CD209 promotes virus invasion into the macrophages, and it results in the release of inflammatory cytokines, interleukin-6, interleukin-2, interleukin-7, GCSF, CC motif, and tumor necrosis factor. And this results in a cytokine release syndrome in patients with SARS-CoV infection. So after the SARS-CoV infection, the virus binds to the ACE2 receptor in the heart, in the blood vessels, in the lungs, and also binds to the CD209 receptors on the macrophage surfaces. And this triggers a series of inflammatory reactions, cytokine release, and which results in inflammations of the blood vessels, the heart, the lungs, and also suppress the immunity. So this explains why patients being infected by COVID-19 are prone to develop a series of cardiovascular complications, including acute cardiac injury, acute coronary syndrome, acute myocarditis, cardiomyopathy and heart failure, cardiac arrhythmia, pulmonary embolism, coronary artery dissection, cardiogenic shock or circulatory failure, or even cardiac arrest. So I'll go through these complications one by one. Acute cardiac injury is defined as cardiac troponin elevation greater than 99% of normal, plus or minus the presence of abnormal ECG or echo. Abnormal ECG or abnormal echo are not essential for the diagnosis of acute cardiac injury. So some of these patients had normal ECG, normal cardiac function, but they had elevation of cardiac troponin greater than 99 percentile the upper limit of normal. They are commoner among older patients and those with comorbidities. So what's the prevalence of acute cardiac injury in COVID-19 infected patients? So among those hospitalized inpatients, the prevalence is about 7 to 20%. Among ICU patients, it's more than 20%, about 22%. For COVID-19 non-survivors, the prevalence of acute cardiac injury is nearly 60%, versus only 1% among those COVID-19 survivors. Acute cardiac injury is associated with increased mortality. Death rate was increased by 4 to 11 times versus those without troponin elevation. And it is associated with increased risk of cardiac arrhythmia, ARDS, coagulopathy, and the requirement for mechanical ventilation. When you look at this temporal trend of high sensitive troponin elevation among hospitalized COVID-19 patients, you could see among non-survivors, there was a drastic increase of troponin level throughout hospitalization, while for survivors, the troponin level remained low and very steady throughout the course of hospitalization. Among people with pre-existing cardiovascular disease and elevated troponin T, the mortality rate was almost 70% in a cohort of 187 patients in China. Among those patients without cardiovascular disease and normal troponin, the mortality rate was about 7.6%. So the presence of troponin elevation on the background of pre-existing cardiovascular disease was associated with 9 times increase in mortality versus those without pre-existing cardiovascular disease and normal troponin. For patients without cardiac injury, the mortality rate was about 4.5% in another cohort of about 400 patients. And the mortality rate was increased by 11 times for those with cardiac injury, in the range of about 51%. How about acute myocardial infarction? Patients with COVID-19 could also develop acute myocardial infarction secondary to acute coronary plaque rupture, cytokine storm, hypoxic injury, coronary artery spasm, microemboli, coronary artery dissection, or direct endothelial injury. Systemic data on acute myocardial infection among COVID-19 patients has been lacking. There are only case series and case reports. There was one first autopsy report of a 53-year-old woman with pulmonary renal failure who died from a COVID-19 infection in Jingyin Hospital in Wuhan. And the post-mortem findings showed evidence of acute myocardial infarction. This was unpublished data through personal communication with a pathologist from the Chinese Academy of Science. And this has been documented in a brief report on the 11th of March in Lancet. In an Italian study involving 350 patients, among those who died from COVID-19, about 1/3 of these people had ischemic heart disease. And this is a very old cohort, and the mean age of these patients was almost 80. There was a recent case series published in New England Journal of Medicine. This case series reported 18 patients who presented with ST elevation and COVID-19 infection. Interestingly, only about 1/3 of these patients complained of chest pain. And among those with confirmed acute myocardial infarction, only about 60% of these patients had chest pain. Among this cohort of 18 patients, about half of them underwent coronary angiogram, and obstructive coronary artery disease was found in 67% of the patients. The prognosis was extremely poor. The mortality rate was over 70%, 50% among those with confirmed acute myocardial infarction, and 90% among those with non-coronary myocardial injury. So the absence of obstructive coronary artery disease in this group of patients with ST elevation actually carried an even worse prognosis than those with obstructive coronary artery diseases. There have been case reports of spontaneous coronary artery dissection among patients with COVID-19 infection. And this Italian group reported a patient with coronary artery dissection in the right coronary artery, which had been confirmed by invasive coronary angiogram. As you could see, the dissection flap in coronary angiogram in the right coronary artery, highlighted by the white arrow, and also by optical coherence tomography. For those of you who do not perform invasive coronary angiogram, optical coherence tomography is a kind of infrared intravascular imaging technique to study the coronary vessels. And you could see in the optical coherence tomography, there's a clear delineated dissection flap within the right coronary artery. And this dissection flap could predispose to thrombus formation and coronary artery occlusion. However, this patient was managed conservatively for medical therapy. Patients with COVID-19 infection are also prone to develop viral myocarditis. The first case report of fulminant myocarditis was by the Chinese group, published in Case Report and Insights in March. There was a case series of 150 patients of COVID-19 infection. Among this cohort, the mortality rate was quite high. 68 of those patients died. And among these patients, 7% of the deaths were attributed to myocarditis and circulatory failure. And about 1/3 of these cases, myocarditis might have a contributing role to mortality. And this is one classical example of COVID-19 fulminant myocarditis, which the patient was saved with methylpenicillin treatment and human immunoglobulin. And this patient's diagnosis of myocarditis was only clinical. There were no MRI or myocardial biopsy evidence. But you could see there was a global ventricular dilatation in both the cardiac CT and also chest X-ray. And after treatment, you could see the cardiac thoracic ratio normalized. And there was also evidence of pulmonary congestion, pleural effusion in the cardiac CT as well. This is another case report showing the MRI evidence of COVID-19 myopericarditis. It was a 53-year-old lady who presented with fatigue and a confirmed COVID-19 infection The ECG on admission showed diffuse ST elevation over inferior leads and anteroceptor leads. And the patient had no congestive heart failure, but the troponin T and NT-proBNP were elevated. Coronary angiogram was normal. The patient received cardiac MRI, and the cardiac MRI showed biventricular late gadolinium enhancement and also a rim of pericardial effusion. You could see the white area here referred to the late gadolinium enhancement suggested underlying myocardial necrosis and fibrosis. And also the T2 sequence of MRI showed marked biventricular interstitial edema. So water signal is bright in the T2 sequence. You could see the very remarkable diffuse bright signals in the myocardium suggestive of interstitial water, biventricular myocardial edema, and also pericardial effusion. So this patient had an MRI evidence of COVID-19 associated myopericarditis. However, has there been any pathological evidence of COVID-19 infection in people with clinical diagnosis of myocarditis? This case report reported a 50-year-old man with clinical diagnosis of myocarditis and ARDS, and the post-mortem finding suggested diffuse alveolar damage, interstitial inflammation in the lungs, also inflammation in the liver. In the myocardial biopsy, there was evidence of interstitial mononuclear inflammatory infiltrates, but there was no other substantial damage. There was no viral inclusion body. So this is the first pathological evidence of myocardial inflammation in a person with clinical diagnosis of COVID-19 associated myocarditis. However, not until recently, the Italian group published the first case report of biopsy-proven COVID-19 myocarditis. A 69-year-old man with COVID-19 infection, ARDS, and cardiogenic shock with LVEF of only 25%. He was treated with ECMO and died tragically due to septic shock. The post-mortem, the pre-mortem myocardial biopsy showed interstitial and endocardial inflammation with vacuolated macrophage in the myocardium. And on the right panel, you can see under electron microscopy, there were virus inclusion bodies, as shown by the red arrows, with protein spikes, as pinpointed by the green arrow in the myocardial interstitial cells. So this is the first case report of proven COVID-19 virus inclusion bodies in the myocardium in a patient who died from COVID-19 myocarditis. Patients with pre-existing heart conditions like congestive heart failure are 10 times more frequent among patients with acute myocardial injury in the COVID-19 cohort. In a US study of 21 critically ill ICU-admitted COVID-19 patients, 1/3 of these people developed dilated cardiomyopathy, but 40% of these patients had pre-existing heart failure. From the case series in the Wuhan hospitals, involving over 190 patients, congestive heart failure was reported in 23% of patients. They're more common among survivors, more common among non-survivors. About half of the non-survivors had congestive heart failure compared with only 12% in the survivors. So this is another case series of 4 end-stage heart failure patients aged between 11 to 67 with NYHA class 4 heart failure. They all had BNP elevation and troponin elevation, and their prognosis was extremely poor. The mortality rate was 50%, and both of the succumbed patients had ARDS. You can see when we look at the plasma NT-proBNP level, it had a positive correlation with the plasma troponin T level. And among patients with troponin T and NT-proBNP elevation, in this cohort of 180 patients, you could see for those non-survivors, there was a drastic increase of the NT-proBNP level throughout the course of hospitalization. And the median NT-proBNP level was above 260. About 28% had myocardial injury, which resulted in cardiac dysfunction and arrhythmia. However, among those survivors who survived to hospital discharge, the trend NT-proBNP remained quite steady throughout the course of hospital admission. Patients with COVID-19 infection are also more prone to develop cardiac arrhythmia. Currently, there's lack of systematic data, but palpitations have been reported in about 7% of COVID-19 patients. In a cohort of 130 patients with COVID-19 infection in Wuhan, about 17% of patients had cardiac arrhythmia, and among ICU-admitted COVID-19 patients, about 44% of these patients had cardiac arrhythmia, compared with only 7% among those non-ICU COVID-19 patients. Severe cardiac arrhythmia, including but not limited to ventricular tachycardia, ventricular fibrillation, could result in cardiogenic shock, hemodynamic compromise, and sudden cardiac arrest. VT and VF has been reported as a complication of COVID-19 infection in 6% of patients, and is significantly higher in those patients with coexisting troponin T elevation and acute cardiac injury. So what's the mechanism of cardiac arrhythmia in COVID-19 patients? After COVID-19 infection, the COVID virus could directly invade the myocardium and the heart, causing myocardial inflammation, myocarditis, acute cardiac injury. It could also invade the immune cells and macrophages, resulting in release of cytotoxic cytokines, resulting in a cytokine storm. And these cytokines, including interleukin-6 and interleukin-7, could also result in myocardial and vascular inflammation. Patients taking COVID-19 medication could also be more prone to develop cardiac arrhythmia, because many of these drugs used to treat COVID-19 could prolong QT interval, and QT prolongation could result in cardiac arrhythmia, ventricular arrhythmia, and sudden cardiac death as well. So drugs used to treat COVID-19 could result in QT prolongation and precipitate cardiac arrhythmia, especially in those patients with pre-existing cardiac conditions and in those who are taking drugs, which could also prolong QT. Among these drugs, chloroquine and also Kaletra, which is a combination of lopinavir and ritonavir, the drug used to treat HIV, could also prolong QT interval. So people using these drugs are more prone to develop long QT and cardiac arrhythmia. So the ESC has issued a guidance for the diagnosis and management of cardiovascular diseases during COVID-19. And the last version was updated on the 21st of April. So in this recommendation, for those people receiving QT-prolonging COVID-19 treatment, we should closely monitor the ECG and QT interval. If the QTc interval at baseline is greater than 500, we should really be very cautious about initiating these COVID-19 treatment and have to balance the risk and benefit of using this QT-prolonging COVID-19 medication. Among those people with normal QTc at baseline, we have to closely monitor the serum potassium, magnesium level. After starting the COVID-19 medication, we have to repeat the ECG 1 to 2 days after starting the medication. If the QT remains below 500, we could continue the medication. If the QTc prolongs to about 500 milliseconds, then we should be very cautious about down titrating or even withdrawing these COVID-19 medication. Patients with COVID-19 infection are also prone to develop venous thromboembolism. And the mechanism would include systemic inflammation, disseminated intravascular coagulopathy, and prolonged immobilization. D-dimers are found to be elevated among COVID-19 patients. D-dimer greater than 0.5 milligram per liter have been found in more than 40% of COVID-19 patients, and the percentage is even higher among those severe diseases. It's a predictor of mortality. D-dimer level is higher among non-survivors versus survivors, and D-dimer level on admission were higher in those needing critical care. So D-dimer is also a prognostic marker among people with COVID-19 infection. This is a case report of a patient with COVID-19 infection who suffered from a right middle lobe pulmonary artery embolism. And the other heatedly debated topic is the use of ACEI and ARB among COVID-19 patients, to use or not to use. So ACEI could be a double-edged sword. On one hand, it could inhibit the ACE1 and inhibiting the angiotensin II conversion, therefore inhibiting vasoconstriction, inhibiting cellular inflammation, fibrosis, and proliferation. But on the other hand, it could potentially upregulate ACE2 expression on cellular surface. So in theory, overexpression of ACE2 on cellular surface could enhance the risk of COVID-19 infection because the SARS-CoV-2 virus uses ACE2 for cellular entry. However, when we look at the clinical data, this study was just published on the 17th of April. In this retrospective study of over 3,600 patients, we could see that among those people who took ACEI or ARB, the mortality rate was 3.7%. And among those not taking ACEI and ARB, the mortality rate approached 10%. Another cohort of over 1,000 patients, among those taking ACEI, you could see the mortality Kaplan-Meier survival chart. Among the unmatched cohort, those people not taking ACEI and ARB had higher chance of dying from COVID-19 infection. Even after propensity matched analysis, you could see among people taking ACEI and ARB, the mortality rate was much lower compared with those people not taking ACEI and ARB. So from retrospective observational clinical data, there is no evidence to suggest that taking ACEI or ARB would increase the risk of mortality among people with COVID-19 infection. Currently, both the ACC and ESC guidelines did not recommend cessation of ACEI and ARB among people with COVID-19 infection. And for those people with hypertension and with a particular indication for ACEI and ARB, they should continue to take these drugs, even during ACEI, during COVID-19 infection, according to the ESC guideline. And last but not least, I would like to briefly touch on the interaction between COVID-19 treatment and cardiovascular drugs. Chloroquine have been used to treat COVID-19, but you could prolong QT. So we had to be very cautious when we are using chloroquine with other QT-prolonging antibiotics or QT-prolonging antiarrhythmics. Antiviral drugs could also interact with anticoagulants, statin, NOAC, and antiarrhythmics. Because some of the antiviral drugs, like Calictron, could also potentially prolong QT interval and promote cardiac arrhythmia. So there was a publication in the JACC in March this year, and there's a good recommendation regarding the dosing and adjustment in the setting of medication interaction in COVID-19 patients. So we have to pay particular attention to Calictron. This drug interacts with anticoagulants, so we have to reduce the dose of certain novel anticoagulants. We might have to up-titrate or down-titrate certain antiplatelets. We have to down-titrate the dosage of statin because of the drug interaction. And we might have to be very cautious when we're using QT-prolonging antiarrhythmics because of the risk of QT prolongation and cardiac arrhythmia. And chloroquine had a similar problem with QT prolongation. So in summary, SARS-CoV-2 virus causing COVID-19 infection can infect people through the following two mechanisms. It binds to the ACE2 receptor in the heart, lungs, vessels, kidneys, and gastrointestinal tract, thereby downregulating and disrupting ACE2 receptors on the cellular surface, triggering a cascade of cytokine release and systemic inflammation. On the other hand, it suppresses immunity by binding to CD209 on the macrophage surfaces, resulting in immune system dysregulation and cytokine release. And therefore, COVID-19 infection could trigger a series of cardiovascular complications, including acute cardiac injury, acute coronary syndrome, myocarditis, cardiomyopathy, heart failure, cardiac arrhythmia, pulmonary embolism, cardiogenic shock, circulatory failure, or even cardiac arrest. And people who are older, people who have hypertension, diabetes, pre-existing cardiovascular disease, immune system inactivation, coagulopathies, immobility, are more prone to develop these COVID-19 complications. And COVID-19 treatment could potentially interact with cardiovascular drugs. There is currently no evidence to suggest use of ACI or ARB will increase harm or cardiovascular morbidities among patients with COVID-19 infection. People with indication to take these drugs should continue ACI or ARB during COVID-19 infection. QTc prolongation caused by the COVID-19 treatment will trigger malignant cardiac arrhythmia, and we should be very cautious when we are using these drugs with other potentially QT-prolonging medications such as antibiotics, antifungals, or antiarrhythmics. COVID-19 treatment could also interact with anticoagulants and statins. So we have to be very cautious in titrating these medications when we are using these drugs in patients with COVID-19 infection. So I would like to conclude my presentation here. Thank you very much for your attention.
Thank you so much, Dr. Chan, for summarizing it in a really nice way. Frankly telling, I was really impressed by your details, which you went through. You taught us and shared your information about not just the fatality rate of the global perspective and also your area as well where you're working. You shared the details about its mechanism, not only about the acute cardiac injury, but also about the acute myocardial infarction, or even the acute coronary syndrome, which these patients tend to have. And we are aware, a lot of our cardiac patients are also associated to be having those congestive heart failures, and how the corona tends to affect those kind of patients as well. And it was really interesting to go through how the level of the troponin T and the NT-proBNP as well tends to affect this various serum levels, and further the relationship to the mortality and the morbidity as well for those patients. You were able to share even with a lot of beautiful images about the changes which happens in relation to the myocarditis as well in these kind of patients. And we have, of course, been coming across a lot of these arrhythmia problems, and especially those drug-induced arrhythmias as well. And later on, you also shared your insights about how, what are those different drugs which is being used in the treatment of these patients. And it is very important for any of the cardiology people as well, or any of the medical students as well, or people to know what about the possible drug interactions. So whenever we are trying to treat those patients with any of these cardiovascular disease or for the drugs, how is it going to affect or interfere with those drugs which is being recently advocated, I would say, because not yet we don't have any of the drugs which is US FDA or any of those European Medical Council or any of the approved bodies have said yes to them. But there are some earlier trends. So this is very interesting. And one of the key things which we all should keep it in mind, especially from point of view of patients, that yes, everywhere globally, I think Dr. Chan will also agree with us, is that we are seeing the lower number of patients, even with the acute coronary syndrome as well, who are coming to the hospital. Most likely they are slightly afraid that they may get the infection of the COVID or the coronavirus, in fact, when they come to the hospital. And of course, this is definitely not the case that, you know, there are less number of heart attacks which is happening around the world. No, but possibly due to the afraid. So I would really encourage to any of these people as well who are seeing us that if you feel any problem, if you have any symptoms, you should come and visit your local hospital. So after this brief overview, I did have some curious questions for Dr. Chan. Dr. Chan, what do you think are the practical tips and tricks for our cardiology colleagues, if you would like to share?
Well, I think one of the, thank you, Noreen, for your very nice summary of the talk and your inspiring questions. I think one of the most commonly asked questions is how to differentiate acute coronary syndrome from acute cardiac injury among patients with COVID-19 infection. And so a lot of our colleagues are doing coronary intervention, and this will impose a lot of logistic difficulties managing patients presenting with a suspected acute coronary syndrome. Because people presenting to the hospital, their ECG might show ST elevation, but it's not specific for ST elevation MI. The presence of ST elevation on ECG could be a marker of acute myocardial injury or acute myocarditis or myopericarditis as well. So, and troponin elevation alone could not tell the difference between an obstructive coronary lesion resulting in myocardial infarction from viral myocarditis. So it's very important to take into account of the whole clinical scenario. And a lot of people do not present with chest pain on admission. So when you see troponin elevation in isolation or ECG change in isolation in the absence of coronary artery disease risk factors, in the absence of chest pain or symptoms suggestive of ACS, we should not treat these patients as an equivalent to acute myocardial infarction, because many of these patients do not require invasive coronary angiogram or coronary intervention. A lot of the cath labs in many regions do not have this isolation facilities to accommodate these COVID-19 infection patients. So sending these patients to the cath lab would impose the risk of infection to the healthcare personnel and would cause a lot of false alarms, inappropriate investigations, and over-treatment. So it's very important to take the whole clinical scenario into consideration, starting from clinical history and also risk factor assessment. Say, for example, if you are seeing a young lady below the age of 40, coming to the emergency with ECG showing ST elevation and troponin elevation, you will not activate a cath lab. So on the other hand, if you see a 80-year-old gentleman with DM, hypertension, hypercholesterolemia, chronic smoker, and with a typical angina, then you are much more worried about ACS. And under such scenarios, if you're really concerned about ACS, you could use some adjunctive measures such as non-invasive imaging, cardiac echo, to look for regional wall abnormalities, suggestive of recent myocardial infarction. You could also consider the feasibility of giving thrombolytic in patients with high pretest likelihood of ST elevation MI. And we had a quite extensive experience with using thrombolytic in our locality because emergency PCI services might not be readily available in some regional hospitals in our area. So in those patients with a high pretest likelihood of ST elevation MI, I think non-invasive imaging and also a proper triage and also the use of fibrinolytic therapy would be the first option. For those patients who have failed fibrinolysis or thrombolysis after fibrinolytic therapy, then we might have to consider activation of the cath lab only if we have adequate facilities to contain COVID-19 infection with adequate protective measures for the healthcare professionals.
Thank you, Jacky. This is really indeed interesting to know. I would agree as well that even in UK, we are seeing a re-emergence of the usage of fibrinolysis as well, and it is being re-advised, especially those clinical conditions which you are telling as well, that some of the district general hospitals, even in UK as well, they are being promoted to use fibrinolytic therapy for such cases, and especially in the indications which you already mentioned as well. So we all should keep these things as well in mind. And this is again becomes more interesting to assess those patients and the better usage of triage and also liaising with our colleagues who are there in the emergency rooms as well whenever such kind of patients comes as well. Would you like to share some of those insights? How is the corona situation in the Hong Kong?
Yeah, up to yesterday, we had about 1,000 cases of COVID-19 infection in our locality. We had 4 mortalities. So our case fatality rate was about 0.04%. And over the past 2 weeks, we had no more new cases, no more local outbreaks. So we are looking forward to, if there are no more local outbreaks in the coming 2 weeks, we might loosen the quarantine measures and the infection control measures in the community. And so because we had experience with the SARS infection in 2003, so a lot of Hong Kong people are very health cautious. They're very cautious about personal hygiene, infection control, and every people is wearing masks. So the infection control measure, I would say, is more stringent in our locality, and people are much more health cautious in our community compared with the Western countries. I think this is one of the reasons for the initial success in the control of the COVID-19 infection in our locality, and we have kept the mortality rate below 0.04%, and there have been no more new cases over the
Thank you again for sharing these insights. And I really personally also feel that the Western countries should learn something like this, especially from Hong Kong, about not just the proper usage of the prophylactic measures to contain the infection rate as well. And you already shared that, yes, it was a little bit helpful of your past experience also with the prior infections, similar infections as well in times of SARS. So this is really amazing, and there's no doubt about it. It's also reflected in the statistics as well of lower mortality rate. And in fact, the fresh infection rate has been so much less, in fact. So that's really amazing. So thank you so much, Dr. Jacky Chan, really for sharing all those insights and all. And it was really always amazing as usual to see you again and learn from you. Thank you so much, and I wish you a lovely day ahead.
Thank you. Thank you. Thank you so much.